Okay. Right, if you're ready, can I start the timer? Yes? Can I start
Yes,
the timer?
yes, please.
Sorry. Yes. Started the timer and here is your question.
All right.
I hope it's not difficult for you.
Yeah, I'll try my best, man.
Yes, it's chest examination, respiratory
Yeah,
system examination, but it's a post-op patient, so you have to think.
yeah, yeah.
And patient is having chest pain, sudden onset of chest pain. So what might that be?
Yeah,
And its aim is practice to learn.
yeah,
So
yeah,
one does not have to be perfect.
yes, no.
Right. If you have read and understood, kindly begin your examination station.
Okay, so I'll wash my hands
Yes.
and introduce myself. My name is Dr. David, one of the doctors in the department.
Yes.
And can I confirm your name and age, please?
Yes. You have to tell in a narrative way. You will confirm the name and
Okay, I'll
age
confirm
of the
the name
patient. Yeah?
and age.
Yes.
Sorry, I will confirm name and age of the patient, and then I'll take permission to examine the patient, which will
Yes.
involve um, making sure that the patient's breathing, airways or patent breathing, and then looking at the patient's wounds, and then checking the patient's legs. And I'll ask the patient if he's okay, if he's in any pain. If
Yes.
then I'll check around the patient. Let's look around for the patient's observation notes. Check also if patient's on oxygen, because the nurses may have placed patient on oxygen since he's been breathless.
Yes.
I'll also look around also if patient's connected to any multi-parameter monitors. Then if he is, I'll ask the patient. If patient is on oxygen, I'll ask for permission to take out the oxygen so I can do a full assessment of the patient.
Yes.
So when I take off the oxygen mask, I will then I will um, speak to the patient. If he responds, it means that the airway is patent. Then I'll check for the breathing. Since it's
Yes.
connected the oxygen to the multi-parameter monitor, I'll check for central cyanosis in the mouth.
Yes.
I'll check that the patient is breathing, and check for chest movements. And so for centrality of the trachea, for tracheal positioning, then I'll check if the patient is breathing, chest movements, the upper part and then the lower part, and with my palm around the patient's chest. Then after checking for that, then I will percuss the chest and then listen for breath sounds from the chest.
Yes.
After making sure the patient is breathing well, then I'll go to circulation. I'll check for pallor, for dehydration, and for pallor of check for pallor in the eyes and dehydration in the mouth. Then um, then I'll check for capillary refill, and
Yes.
then check for the pulse of the patient. Then I'll check for
How
heart
much should
sounds.
be the normal capillary refill?
The capillary refill should be in 2 seconds, less
Yes.
than 2 seconds.
Yes.
So check capillary refill, check for the patient's radial pulse, then check for blood pressure, then listen for the heart sounds, and make sure that the heart sounds are normal. After that, then I'll go to disability. I'll use AP. I'll use alert, verbal response pain, and not unresponsive. So if the patient is alert, if he responds to me, I know he's alert. Then I'll expose the patient. Then I'll take permission to check for the patient's occlusion wound. So I'll fit the abdomen, look at the wound for any erythema, any discharges, any undue pain. Then after examining the abdomen for the occlusion wound, then I'll also examine the patient's calf by compressing on the calf to check if there's any pain in the calf for both limbs.
Yes.
Now, Yeah, so after confirming, after running through this, I also look at the patient's folder, patient's observations, and respiratory, the chart for the respiration, check if the patient is very well on oxygen and all that. Then after confirming all this, I'll thank the patient and then help him put on the oxygen mask again, and then help him dress, then present my case.
Yes, before you'll squeeze the legs, you have to ask for the permission as well, or explain.
Okay.
Yeah, so you will do that, and then you'll wash your hands. You'll thank the patient.
Wash my hands.
You'll
Yes.
help the patient in covering and put the mask back, and then okay. Then if you can present your case, please.
Okay, I've examined a 55-year-old man who is 8 days post-operative and noticed to suddenly have chest pain and difficulty in breathing. And on examination, using the care for critically ill surgical patients, and the airway is patent, and then the breathing, the patient is the airway is patent, patient essentially diagnosed. The patient is breathing, the respiratory rate is high, and the patient is breathing well. The circulatory system is normal. The patient is not in shock. But there's the operation wound is well opposed, and there's no evidence of inflammation. But there's pain in the calf, the left calf, which is suggestive of. So with all these things, I'm thinking the patient may have a pulmonary embolism from the left calf. DVT, venous thrombosis.
How would you confirm your diagnosis?
First of all, I'll take bloods for ABGs and lactate. I'll take blood for UNEs, and then I'll also take blood for D-dimer and troponin. In case the patient may have MI, myocardial infarction. I would also want to do a CTPA, that's computed tomography, pulmonary angiography, and then patient may also benefit from a duplex ultrasound scan of the lower limb to rule out the.
Yes, and then maybe chest X-ray, ABGs, and ECG.
Yes, my ECG, echo, chest X-ray.
Yes. These are the more common ones. Okay.
Yes, ma'am.
Right. What if just suppose what should be the management of pulmonary embolism if you have come to your diagnosis then?
For pulmonary embolism, I will, if patient is symptomatic, if patient is asymptomatic, if patient is symptomatic, so he's breathless, and if it is mild, I'll give him treatment dose of anticoagulants.
Yes, which one? And how much dose?
I'll give Clexane, that's an enoxaparin, 1 milligram twice daily, or 1.5 milligram
once you should
daily.
Answer depending upon the pulmonary embolism. If it is non-massive or if it is massive, then how it would differ. Would your
Okay, if it is non-massive, I'll give an IV subcutaneous enoxaparin, 1 milligram twice daily, or 1 milligram per kg twice daily, or 1.5 milligram per kg once daily. If it is massive, I'll opt for thrombolysis, which may be using streptokinase or urokinase.
Then you have to consider hemodynamic is also compromised.
Yes, ma'am. Yes, ma'am. Since for these patients, if the hemodynamics of the patient is compromised, then I'll go for either catheter-directed thrombolysis or open thrombolysis for the patient. But if the patient is stable hemodynamically, I'll manage with enoxaparin.
You'll also get the crash call. Also, you'll put the crash call if patient's hemodynamic is not stable. This extra thing you can add. Yes.
Yes, ma'am. I'll put the crash call, ma'am. Yes, that's true, ma'am.
Just suppose if you were scrubbed and a nurse came and told you about this patient, what would your next step would be?
If I'm scrubbed, I'll put a crash call
Very good. Immediately.
Yes. Immediately.
Very good. Very good. Thank you. Yes.
Thank you very much, ma'am.
Thank you. Yes. Anyone want to give feedback to doctor? Maybe Dr. Hana or Dr. Tashaba, Dr. Sunday, anyone? Yes. Yes, it was good. Yes. Has he covered all the aspects of CRISP protocol? Can you?
I don't think so.
No. So
Yeah,
what he has missed? What he has missed?
Ma'am, as he was a post-operative patient,
Yes.
so he must have gone in the records of what procedure it was and how long it was he's having that pain, and does he have any kind of swelling in his leg or not? Does he complain of
He
any
did
complaint of
examine
pain in the
leg
leg?
afterwards.
Okay.
But then in the
I
beginning,
think
he was supposed to begin with the normal respiratory examination, or
yes.
was he supposed to, at what stage he was supposed to switch to CRISP protocol?
Okay.
okay. Okay, I understand the question. I was thinking that for respiratory, for once you suspect a pulmonary embolism or an MRE, you should go straight to the phase protocol. If it is okay,
Yes. Here, I think I have only written that you have to go for a respiratory system
respiratory.
examination. But then once you are there, what they do, they will not tell you that you have to do the CRISP protocol. Inside you'll
Yes,
go
ma'am.
and you'll see the patient will have mask on, and patient will be a post-op case. So
Okay,
you
ma'am.
know, but at what stage, when would you convert normal respiratory examination into CRISP
To
protocol?
CRISP protocol.
Can you tell me?
Okay, well, okay, I from my own point of view, I think if the patient is centrally cyanotic, I
Yes.
don't know.
Okay.
Okay, with
And
chest pain, okay.
patient has chest pain
Chest
and
pain, okay.
difficulty of breathing.
Difficulty in
Then,
breathing.
yes.
And then, well, maybe,
First,
maybe with,
you'll go ahead almost same with the superficial palpation uh, in this one, and then once patient
okay.
has chest pain, the moment you'll ask the patient will have a chest pain, you'll start with the CRISP protocol. You'll go for
Okay.
airway, breathing, and circulation, and then
Yes, ma'am.
disability. You did tell me all these, but neck veins of neck you forgot to check, and
Yes,
heart
yes, yes.
auscultation,
Okay, I talked
and
about heart auscultation. Okay.
yes, and for wound exposure you will offer, but they will tell you not to. They will tell you to consider.
Okay.
So this, and patient will be like in this point position.
Yes, ma'am.
Okay.
Thank you very much, ma'am.
And you will be provided with the patient file, including the vital charts, FBC and ECG. You'll
Yes,
read
ma'am.
the patient's charts in 6 minutes, and then you will just, yes, and then you will examine the chest from the back only in pulmonary embolism. You will not examine the patient's chest from the front. I think this you had forgotten to
I
mention.
forgot. I didn't mention that.
Yeah. So, all right, you'll go back, you'll listen to this, and you'll correct yourself. And then we'll
Yes,
do
ma'am.
it again, maybe, and then it will be better, hopefully.
Okay, ma'am.
Yes. All right, maybe we should call it the end. Dr. Muhammad's network is not cooperating with him, and Dr. Sandhya's network is not good as well. So, maybe, yeah, we will definitely meet tomorrow, and we will discuss tomorrow. Dr. Tishaba, you can maybe remind me your station for tomorrow.
Ma'am. Okay, ma'am. Ma'am, the same one, the surgical nutrition management.
Nutrition. Okay.
Yes, ma'am.
Yes, that was pending. Yes, we haven't done that. So all right, good.
Okay, ma'am.
All right. Yeah.
Hello, madam.
Yes. Yes.
Madam, can you just repeat the treatment of massive and non-massive pulmonary embolism? I just
You,
can.
doctor. Where is he? Can you please repeat? I'll tell,
Yes, ma'am.
but yes,
Yes.
please. Can you repeat?
Okay. I said for the one that's non-massive with
Yes.
stable hemodynamics. I'm going to give enoxaparin, injectable enoxaparin at treatment
Anticoagulant,
dose, which
yes.
is anticoagulant, which is either 1 milligram per kg twice daily or 1.5 milligram per kg twice daily. Then I'll monitor the patient's ATP. Then if it is massive, the patient will need, I'll put a cash call, call my consultant, and then use the trust guideline. However, the patient will need thrombolysis or thromboembolism or thromboembolectomy. So
In only
that
in
can be done.
case when it is hemodynamics are unstable. But if they're stable, then you can give the therapeutic dose of subcutaneous heparin followed by warfarin.
Yeah,
and that may involve the medical team as well for follow-up.
Yes.
Yes.
Okay. Thank you.
Thank you. All right. And we can maybe